Hello, this is Dr. Janice Williams. This lecture will discuss the advanced practice nurse and the evolving healthcare delivery system. The objectives of this lecture is to describe the advanced practice nurse role in interprofessional collaboration, summarize the history and structure of the U.S. healthcare delivery system, analyze the historical evolution and key factors influencing healthcare delivery, examine the forces driving changes in today's healthcare system, and differentiate between the levels of healthcare, which consist of primary, secondary, and tertiary care. So let's talk about the APRN role in interprofessional collaboration. The advanced practice nurse serves as a clinical leader who helps to coordinate the care of their patients across the diverse disciplines. We do this by facilitating communication, shared decision-making, and patient advocacy. This thus leads to quality outcomes for our patients and their families, while also reducing fragmentation of care. We thus are supported by a team, and we recognize that the patients that we serve have complex healthcare issues that requires not only care by the advanced practice clinician, but all entities of the healthcare team. Let's talk about the definition of what is a healthcare system. Dartmouth College Center of Excellence defines healthcare systems as an organization that consists of either at least one hospital plus at least one group of physicians or more than one group of physicians. For the purpose of this definition, the group and the physicians must include at least 3 primary care physicians. The Dartmouth study evaluated systems on multiple levels. They looked at the individuals, they looked at the hospital, and the system leadership. Dartmouth has identified systems and their component entities by looking at the formal corporate relationship among these entities. While independent practices and independent hospitals do not meet their definition as a system, they still evaluate those systems. Whereas the National Bureau of Economic Research Center of Excellence defines healthcare systems as a group of healthcare organizations that are jointly owned or managed. And these healthcare systems are required to include one general acute care hospital, 10 primary care physicians, with a total of 50 physicians, all located within the single hospital of that region. A third definition by the RAND Center of Excellence defines healthcare systems as 2 or more healthcare organizations affiliated with each other through shared ownership or a contracting relationship for payment and service delivery. For its work, a healthcare system must have at least one acute care hospital and at least one physician organization. Now, the RAND Center of Excellence excludes horizontally integrated healthcare systems. Horizontally integrated healthcare systems consist only of the hospital, so they are excluded. It is notable by the RAND Center that organizations can be members of multiple healthcare systems, such as a physician organization that participates in more than one accountable care organization. The final definition that I would like to talk about is by the Compendium of U.S. Healthcare Systems, AHRQ. And they define healthcare systems as an organization that includes at least one hospital, at least one group of physicians that will provide comprehensive care. They are connected with each other and with the hospital through common ownership or joint management. This definition applies and states that the foundation models are considered a form of joint management, and the joint participation among those providers is an accountable care organization. It is not by itself indicative of joint management. The word group is not synonymous with a separately organized medical group. Hospitals that employ community-based physicians who provide comprehensive care are considered healthcare systems under this definition. So those are 4 definitions of what a healthcare system is from 4 different institutions. So as you can see, the definitions are not consistent across the board, but they have their own criteria. Let's now move from defining a healthcare system to talking about the history of healthcare systems within the U.S. In the early 1900s, care centered around private practice and hospitals. Around the 1960s, it was the introduction of Medicare and Medicaid, and this helped to reshape access to care. In the 1980s and 1990s, managed care and cost containment initiatives emerged. And today, the focus of U.S. healthcare is on value-based care, equity, and population health. So let's talk about 4 common healthcare systems: the Beveridge model, the Bismarck model, the National Health Insurance model, and the out-of-pocket model. What is the Beveridge model? It's a healthcare provided and financed by the government through taxes. This model is used in places like the UK and Spain. The Bismarck model uses an insurance system. It is usually financed jointly by the employers and employees through their payroll deduction. I want you to think of places like Germany and Japan. Whereas the National Health Insurance model, it blends both the private sector providers, but payment coming from the government-run insurance programs. This is places like Canada. And then finally, the out-of-pocket model. And this is commonly being developed in nations where individuals pay for their services directly. So again, the 4 models: the Beveridge model, the Bismarck model, the National Health Insurance model, and the out-of-pocket model. So now let's talk about the structure of the healthcare delivery system. How are healthcare systems structured? When you think about the providers, I want you to think about, we have hospitals, we have clinics, we have community health centers, we have private practice. I would venture to say we also have moved to home health services that provide care to patients in their homes. When we think about the payers, we have our government programs, our private insurers, and our self-pay patients. And who are the regulators of these systems? We have both state and federal agencies, the CDC, the FDA, and the CMS. And of course, we also have within this system our consumers. These are the patients and the families that engage in this care. So when you think about the structure, I want you to think about 4 things. Who is the provider? Who are the payers? Who are the regulators? and then who are the consumers. So what factors influence healthcare and the development of healthcare? We have factors such as demographic shifts, technological advances, policy and economics, and then social determinants. So when you think about demographic shifts, we think about our aging population and the chronic disease prevalence that we are seeing now. Technological advances, especially since COVID-19, we've seen an uptick in telehealth, AI, and for several years, we've seen electronic medical records or our EMRs. Other factors are the policies and the economics, healthcare reform, cost of containment, reimbursement models. We are today living in real-time changes on what are the policies and the economics that are establishing what our healthcare looks like. What are those influences? Because it is changing. Those who can afford care, those who cannot. The revamping of Affordable Care Act and things of that nature, the revamping of our Medicare. So policy and economics has a big impact or big influence on how healthcare develops. And finally, but not least, is let's talk about the social determinants. Who has access to healthcare? The education provided, and the healthcare disparities, and the impact currently that we are seeing in healthcare environments as a result of social determinants. Individuals having less access, not having the education, and definitely having the disparities, lack of funds to pay for or to receive the services or get the services that they need. Let's talk more now about the forces that are driving change in healthcare. Four forces that I recognize is the rising healthcare costs and the demand for efficacy. So those are the yin and the yang. We do have rising healthcare costs, but what we see is the demand for efficacy has both its benefits and its risk and its challenges. The, the human resource reduction, the limitations in the nursing profession, the limitation to funds to provide the things necessary to have an adequate healthcare system. All of those contribute to the rise in healthcare costs and the demand for efficacy. We also have the emphasis or the increased emphasis on the quality and safety. We have regulatory bodies and organizations trying to establish criteria that will help to improve the quality and safety of care. However, there are changes that are going forth as we see that the quality and safety, especially in the United States, is not at the level or the of which we would hope. There's also the integration of evidence-based practice and informatics, the shift towards preventative and community-based care. So these are some driving forces of how and why we're seeing changes in our healthcare system that as the advanced practice clinician, you must consider. The cost of healthcare, how to be efficacious, the quality and safety in which we provide care, making sure that we're using evidence-based practice and the use of technology to help us deliver care, even when it comes down to telehealth medicine. How do we use technology? And as we spoke on briefly earlier about our increased age of our patients, when you think about that, how do we bridge the knowledge gap of the elderly with informatics and technology? If we're moving toward a technological system, however, we know there's a knowledge gap for our seniors who are the largest group of healthcare receivers. And then finally, the shift towards prevention and community-based care. Healthcare has transitioned and changed from being a medical model disease treatment to now preventative and community-based. And with that transition requires the transition in resources, the transition and us to relook at what are the policies, what are the laws that will help us to change our healthcare system in an efficacious way that is impactful and beneficial to those who will be receiving the care. So let's talk about these driving forces in healthcare from 4 standards. 1, infrastructure. That's looking at our hospitals, our clinics, and our specialized facilities. 2 is our workforce, physicians, nurses, and allied health. 3 is finances. How do individuals pay for the care that they're receiving? How about the public taxes, the private insurance, and the out-of-pocket payments? And then 4, governance, the regulatory body and agencies that oversee the quality of care. Let's loop back and talk about the infrastructure. Hospitals, clinics, and specialized facilities. We have these institutions, but do we have enough of them to treat the growing need of our patients, of the constituents, those who will be needing to receive the care? And the ones that we do have, do they meet the quality standards? Is the structure, are the resources in these infrastructures appropriate? When we think about the workforce, our physicians, nurses, and allied professionals, when we think about the shortage of primary care physicians, of advanced practice clinicians, and even our allied health professionals, when we think about the changes that may be coming forth with declassifying certain professions that are no longer or may no longer be considered professions, so these individuals who may want to enter the workforce in these specialties may have limitations because they are unable to afford the necessary education. When we think about finances, recognizing that the increase in taxes, the increase in cost of daily living is limiting individuals' ability to pay for health care and not having the funds to pay for their medications, to pay for specialists, to pay for those services necessary to help them to maintain a quality of life. And when we think about our governance, these regulatory bodies that implement policies, who's overseeing that these regulatory bodies are doing what they need to do? And if institutions, if organizations, if individuals within the workforce are not abiding by these regulatory body standards and practicing the policies and procedures established, how are they being held accountable? And how is the population being made aware of these things? So let's talk a little about the delivery levels of healthcare that occurs. We have primary care, secondary care, and tertiary care. So when we think about the levels of healthcare, I want you to think about first, primary care is that first contact. That's that preventative and wellness services. This is often where our advanced practice clinicians see their patients. This is the family practice setting. Patients coming in trying to prevent illness and maintain wellness. We have secondary care. These are our specialist services and our acute interventions, our urgent cares. This is where we have our specialists like our ophthalmologists. We may even have our infectious disease, our nephrologists. These may be individuals that patients have to see once they are diagnosed with the disease process, and they're helping these individuals to obtain their highest level of wellness. And then we also have tertiary care, highly specialized services, often the hospital-based. So when you think about not only the change in our healthcare systems, the levels of our healthcare systems, we have to think about how do we as advanced practice clinicians maneuver in this complex system? How do we understand the diverse levels of our healthcare systems and not only understand them, but how do we impact our patients in a positive manner, knowing that there are so many levels? I would venture to say we do this first by first understanding what is our healthcare system that we're working in. What are the organizations that we are a part of that we can advocate and become active in formulating policies that are beneficial to our patients and to healthcare system overall? And that we also look at each individual patient. What are their limitations? to acquiring healthcare, and what are the resources out there for help for us to mitigate them. We may not be able to change the entire healthcare system, but we can make an impact little by little, day by day. But it begins one with knowledge, two with understanding, and three with developing a plan. This plan is not just for us practicing every day, but it's also to be sitting at the table, becoming part of the policymakers, developing solutions, and helping others understand what the needs are, because we are there in the rooms with our patients, and so we can bridge that gap. And then looking at how can we, if at all, create a structure and systems that will help improve the patient care that our patients receive. So what are some of the takeaways I want you to receive? One, we advanced practice clinicians are central to coordinating care for our patients. Remember, our patients is at the center of what we do. Two, the U.S. healthcare system, it is continually and ever evolving, both with policies, technology, and social change. It is our responsibility as an advanced practice clinician to be aware of the evolution and be a part of the solution. And three, understand that system structures are needed and that we as APRNs must understand those structures, and we can lead effectively as being part of an interprofessional team that collaborates with our healthcare partners, both medical and outside of our profession. These are my references. Please take time to also review the content in your textbook and to enhance your knowledge. And I look forward to having a more robust conversation with you during lecture.